Hello, and welcome to this Elos webinar. Today, we're going to talk about our new product, the hybrid-based G. And together with me, I have my very good dental friends. We have Dr. Martin Wanendeya and Steve Campbell, dental technicians. I'm going to let you introduce yourself. Steve, will you start?
Absolutely no problem at all. Can you hear me okay?
Yeah, we do.
Yeah, there we go. Nice and professional. Start with, can you hear me okay? Okay, Steve Campbell, obviously working here out of Nexus, but I'm really fortunate that we're part of a group that is very lucky to be involved in early development and testing. And we were very fortunate to be involved in the early journey of this hybrid-based G along with Dr. Martin Wanendeya. And I just can't wait actually to share what we've been up to and what it's come to at the end. So I'm really looking forward to this meeting. Over to you, Martin.
Hello, my name is Dr. Martin Wanendeya. I'm a dentist based in Clapham and Balham in London at 10 Dental. And like Steve, I've been incredibly fortunate to be a part of this journey and to see how Elos have been so responsive to the clinical needs that we have in practice. I'm really looking forward to showing you how we use the hybrid-based G in practice, how it's utilized, and obviously some of the thought process behind what Elos have. But I'm really looking forward to this, and I'm really looking forward to showing you some of these cases that we've been working on live now.
Thank you, Martin. And on a technical side, we do have the option to ask questions within this webinar. You have a small text box with a question mark icon. If you want, you can post a question in there and we'll try to answer it. Both Martin and Steve do love to talk a lot, so I will try my best to moderate this dialogue. But the intention with this is that we're going to talk a little bit about the challenges that may occur on both the clinical side and the technical side, on the lab side. And hopefully we'll be able to offer you some insights into solutions that might mitigate some of these challenges, especially with our new hybrid-based G. So Martin, will you kick us off?
Yes. So what I'm going to talk about first really is I'm going to talk about the challenges that we face and the challenges in terms of how implantology has changed and how sometimes the componentry has not kept up with the challenges that we face. And if I pick on these 4 points, because these 4 points are things we face in practice every day: immediacy, our patients and we want to put in more implants immediately into sockets. This also means that these implants are deeper, and the implant depth has changed in the time that I've been working. Also, when we're placing implants immediately, we need to put the implants into the bone rather than trying to angle them, so the angulation becomes an issue. And we're also going to talk a little bit about emergence profiles and why that is now such a hot topic in implant aesthetics. If I just start off with showing you this implant that's been placed immediately, what you can see here as you look at it is you can see that the angle, the ideal angle that the implant's been placed at, meaning that in order to have angles, in order to have the screw access hole not coming through the top of the implant, it has to come at an angle, as you can see there. So really, quite often we face this issue: where do we put the implants? Do we put them in the ideal position for the bone and have some angle correction, or do we put them in straighter and have a shorter implant? And I prefer this method because I have the tools to be able to deal with this. I also want to just summarize some of the issues that we face in this case here. It's a patient who's come in. She needs to have the upper left one replaced. We can see the extent of the bone defect. We've gone through, I'm not really here to talk about the clinical things, but we've gone through, we've placed an implant, we've done some connective tissue grafting. I want you to note 2 things. This is a standard 1 mil collar height cylinder. You'll see that the cylinder is a long way down. The collar height of the cylinder is a long way down. You can also see that the cylinder is not as tall, and we'll talk about how that causes issues further down the line. Just carrying on with the case, we carry on, and this is the patient after a period of healing. And the patient goes back to their dentist, and this is the point where they go for a restoration. I get these lovely photos as they go through the process. This is the final, but really the story comes in this radiograph here. And if you look really closely here, what you can see is the difference between when I've placed the implant immediately and the emergence profile of the component that I've used, and the emergence profile of the component that's been used by the referring dentist. And even though for now this looks relatively stable, the question we should ask ourselves is what's going to happen to this over time? Because is it that I'm just being a little bit fussy and we should accept this, or do I know what's going to happen? And really, I'm just going to delve into very briefly another case where we're seeing the effect of the wrong collar height and the wrong component over a period of time. This implant was placed at the subcrestal level, as these implants are. Having been placed at the subcrestal level, when it's been restored, the incorrect profile has been used. So really, the bone in the past on this implant would have been somewhere up to here. And when the bone has been squeezed by this component, over time, we've had some issues. The issues have led to this. So we can see when the patient's been referred here, we've got lack of bone, we've got an area there of chronic irritation and inflammation. And when we've had a look at everything, this patient has had to go through the removal of the implant, having removed the implant, the whole reconstruction of the jaw in this area, having waited for that to be reconstructed, replacing the implant, putting in a component with the correct profile. And once we put this in, look at the difference here. We can see the original, how the patient came in. We can see the patient with the implant in. We can see a correct component. We can see the final implant restoration there. And this is with a custom abutment. So with the correct contour, we can see how we've got beautiful, healthy tissue. And this is, I have to thank Dr. Shravan Chawla for this case, finishing this case off nicely after I've done the surgery for this patient. So really what I want to say is that these challenges that we face in terms of the angulation, in terms of implant depth, in terms of, as well as that, in terms of implant depth, also in terms of, making sure we've got the correct contour are things that really, we need to address. So hopefully that gives you an insight as to some of the challenges that we face. And I'm now going to basically pass over to Casper to talk through, hopefully, some of the solutions that we can use to address these challenges.
Yeah, thank you. Thank you, Martin. Let me just share my screen. So what I would like to show you with this one, as both Steve and Martin mentioned, they have both been part of the development of this product and also other products. And I would like to talk a little bit about the philosophy that we kind of put into the this product, the new hybrid-based G. And it kind of all started with looking at the evolution of tie bases in general. So if we look at this kind of graph that I have here, we have like from a very low level of customization to a very high level of customization. So we have like a stock abutment on the low level of customization, and in the end we have like the pinnacle of a customized abutment that is fully customizable. And if you look through this terms of innovation and customization, we'll say, well, we started digitalizing the first tie bases, maybe with the Spheric tie base, where you had, again, a very low gentle height. We have a very smooth cylinder, not ideal for bonding, which we will come into later. But at least now we have a higher level of customization. Next iteration could be tie bases, hybrid bases with a higher chimney, maybe mechanical retention for bonding, angulated screw channels, and so forth. But still, we have a higher level of customization, and the innovation is kind of going up. What we wanted to do with the hybrid-based G was basically to come closer to a customized abutment. I know, Martin, you'll touch a little bit about that later and have some good feedback on that. But what we have now is we try to come closer to a customized abutment with having, of course, multiple gentle heights, but also we focus a lot, and based on the feedback from Martin and Steve, we focus a lot on the concave design of the gingival. So of course we have gentle heights, but we have a very narrow and concave design to mimic the possibilities of designing customized abutment. We have a tall chimney, which is cuttable. We have our mechanical retention, the grooves on the side of the chimney to improve the retention. We have an improved version on that, and we'll talk more to that later. And of course, we have a cuttable chimney, but it's not only cuttable in the horizontal plane. We actually added in what we call the guide cut, which is 2 cuttable features in a 25-degree angle plane to help these interior restoration and to achieve these optimal aesthetic results. So hopefully, as you see here, we have the cut planes, both the horizontal and the angle planes, and we also have this very nice narrow concave shape for the gingival shape, and hopefully this will actually help, we hope, with some of the challenges that both Martin and Steve face on the clinical and on the lab side. So I'll let you take over from here.
So I'm just going to jump in quickly here for a second, and I'm just going to really talk about another part of that, Casper, which maybe I didn't emphasize enough when we spoke before, which is not only the height, but the angle. Because what you can see here is this is another tie base. This has a good collar height, and as opposed to the ones I've shown before. But 2 things. One is I've had to still narrow this down to get the profile that I want for this case. And the second part is it doesn't have angled screw access, because when you create the angled screw access, quite often you have slightly less material palatally, and Steve will go through that in a little bit. Again, another high base, so quite often we end up having to reshape them to get to the ideal shape. And I'll talk in a minute once Steve has had some commentary on what the ideal shape is and how we've come to that conclusion in terms of the literature in and around that.
Great, thank you.
Steve, if I can get your microphone on, please.
Yeah. No, I'm just lining up, so we're ready to share it. Okay, so let me just bring this one up so I can show you the... Okay, you should be seeing this now.
Yeah, you can see.
Okay, so basically, everything that we've just discussed, really, Martin showed you the cases, and he showed you the issue we're seeing with more and more commonly, these deeper subcrestal implants are coming into the lab, which means that we're more and more often getting the issues where we're being asked to make sure that we're making very narrow chimneys and only fluting as we start to get towards the CEJ, the crown zenith. Now, interestingly, this is what we've been doing with custom abutments up until now. So almost every case for us has been a custom, because it's the only way we could guarantee getting that nice shallow narrow transition and then the fluting out. And we wanted to avoid this. You know, I'm not criticizing other technicians here. I've seen this used all over in every lecture I've gone to. They get a tie base. You can see the very dense pure white there is a very strong zirconia they put on to make their customization. Then obviously the more translucent is probably an Emax on top of that to get the aesthetics. But it's all kind of compromised because it's so bulky down there at the neck, and it's causing that kind of problem. So we don't want to do that. And the issue we've seen is, even with most of the competition, that has been what's happened. They're quite deep, and which means they're always quite close to the bone. So I'm going to show you a case that was done with a specific tie base and then switch. So if you look on the left-hand side, okay, the height, not the worst, but it's not great. But if I look on the right-hand side, my concern is it's only straight. So if I try to get longer to get more height, I'm coming through the buckle. That's about as much as I can get away with buckling. So looking at this here, you see the silver in this is the current height and diameter of that tie base, as opposed to using the HBG in the blue. We get a lot higher up and a lot narrower. Just look at how thick that zirconia is from the old solution to where the new solution would be. That's a huge amount of lip down close near to the bone. So we're going to get away from this shorter one. We're going to extend it up. And now, as Casper's mentioned, with this new feature, the angle cut, we actually get an ideal abutment We get it well away from the bone, very nice, narrow fluted emergence to allow us to get the kind of designs we're looking for. And this is what this angle cut looks like in practice. This is what we're doing with our anterior cases. And this is great because it means that the surgeon isn't compromised. They can angle that buckley as they normally would, and then they can rely on us to still get the right abutment in there, rather than having to bring it more palatal. My screen is still on, isn't it? So this obviously just shows you the options. You've got various heights, and I've got a couple of cases we'll show you, but also this one. This is the major change for us in what we can do with our planning. And this kind of comes into what we've been doing in the past with the custom abutments. So look at that narrow fluted emergence and then look at the transition. Well, that's going to be a HBG going forward, because actually all of my biggest compromises have been catered for with a solution we never had. So what we're now doing is, instead of having the trade-off and compromise, we're actually getting to use a customized solution, or a stock customized solution. I think we're still trying to find a name for this brand new solution, if I'm honest. And we get away from these problems of surgeons constantly having to say to us, please be very careful of bone impingement. Please only do the fluting as you get further up. So we're getting those gingival heights. And I remember when we first discussed gingival heights, and they spoke to me as a lab, and I was like, oh, 1, 2, 3. And then they spoke to Martin, and he was like, more. So you get, a completely different viewpoint, because we want to avoid this problem. So in just a very quick nutshell, technically, that's what we overcome. We've got away from the tissue impingement. We now have solutions for a much bigger body to retain the crown, and much more peace of mind that it's actually going to be the right solution going forward. So I'm just going to unshare myself and hand over to either you, Martin, to show a case, or you, Casper, if you've got any comments on that.
Oh, thank you, Steve. Thank you for that. Martin, please go ahead.
Yeah, so what I'd like to jump in on is a couple of things to do with that. The first is to show, let's talk a little bit about the emergence profile, and let's talk about the customization, because those, I think, are two really, really good features. Steve has shown you this, and he's already shown you how this works in practice. So you'd have seen how, we've got the different angle cuts and guide cuts that we can do. But I think one of the things that's very clever that's happened at Elos is this number of heights. Because when Steve and Casper got in touch, says, oh, we're doing 1 and 2 and maybe a 3, and my first thought is, you're going to need a 4 with the way that people place implants. You're going to need a 4. So by having the different heights, it gives a lot of flexibility. And I think one of the cleverest things from the engineering perspective was having the 2 screw heights. So the 3 and 4 mil come at a different screw height, meaning that we have enough material on the palatal aspect when we are placing those implants a little bit deeper, rather than having issues that you'll see in one of the cases I've seen. And it means that, if we just take this to its conclusion, and I think I thought about this took me a little while of thinking about it. So for each implant, say for I'm going to pick a 3.6 millimeter EB, we've got 4 different heights. And we've also got, so that gives us our 4 different heights. We can deal with 4 implants in 4 places. And we've also got 5 different ways in which we can customize it. We can have it short, we can have it medium, we can have it tall, we can have the tall angle cut, and we can have the shorter angle cut. So if we think through this gives us, for each of the different collar heights, 5 different ways in which we can customize it. Meaning that if we think about this, there's effectively 20 different iterations for the implant that we've got. Think about that, 20 different ways in which you can cut or you can design an HBG to fit on top of your implant. It means in my head, we've moved away from custom abutment, not moved away from, there is another term. And my proposition is that this should be called a semi-custom abutment. Why? Because it's partly customizable. There's lots of features here that you can customize. And we'll talk a little bit about how you take advantage of this particular solution. Now, the reason why the emergence profile, I think, is really, really important is these are 3 or 4 papers, and I'm just going to spend a few minutes on this slide. For those of you who are online, there are the references if you want to look them up. we know that we've got 3 different zones within a tooth. We know we've got something called the aesthetic zone. So this blue line here describes where we want the gingival margin of the tooth. We then have this other zone here called the bounded zone. And this should be as concave as possible at the time we first put a temporary provisional restoration in. We can bulk it up a little bit with the final, but the idea we have this fluted emergence. And we also have this narrow crestal zone that you see there. And then the other thing is, in terms of materials, we need to have something like this. This is polished zirconia in the subgingival area, as well as titanium. So we know that these are biologically friendly materials. This means that when we look at this crown here that you see going into an HPG, and if we think through the same images that I've shown you, we've got our zones here. And that red zone, the all-important bounded zone, can be really, really concave because of the shape and the design of the Elos HPG abutment that you see there. So really, it's the emergence profiles that have been nailed within this, so that they are based on the biological principles that you see in the papers that I've highlighted just there.
Thank you, Martin.
I really like that, Martin. I was saying we're really struggling for a term, and then you just came straight in with the term.
We're gonna adapt it now. I really like the graphics where you show these 4 implants transition into 20 different iterations that can be done. It's a really good graphic. And to comment on the screw, I think it was important for us from our side to say, well, normally when we talk about angulation and angulation screw channel, is limited by the design of the driver. We're using the hexalobular driver, which allows up to 28 degrees of angulation. That's what we have been saying with all the former hyperbases that we have, is that we can go up to 28 degrees of angulation, but it's all depending on the screw and how it's actually situated from the screw seating, and where the U shape that we call it from angulation in the tie base actually protrudes from. So it was important for us with this new generation that we can say it's not up to 28 degrees of angulation anymore. It is 28 degrees of angulation that you have available. And the way to deal with that is to not change the screw seating area of the tie base, because that is all kept original, but it's basically changing the screw height of the screw head to allow you to have that multiple or the angulation of 28 degrees every time. And it is important, I think, here to mention is that the screw does come included and co-packed with the hyperbase. So it's not like you have to be aware of what screw to order. Everything comes co-packed, just as a small detail. But thank you, Martin.
So, Steve, one of the questions I want to pass to you, Steve, is as a lab, you see this height here that I'm highlighting. How important has it been for you in terms of getting tie bases to stay retained, to have the extra height on these two, 3 and 4 millimeters? I mean, have you noted, how important has that been for you in terms of the design of your restorations, in terms of your confidence with a solution like this?
I love this, Martin, because you're basically making me say how great your decision was, and it was a great decision to have them, because it's actually been a massive game changer. Because exactly as you said, and we see so many of them are now coming so deep subcrestal, where they're really wanting to be able to mature and control those tissues and emergencies, that we are finding ourselves utilizing those 3s and 4s way more than we first thought we would. And that's probably, when you showed the evolution earlier, Casper, of how abutments were, you kind of get used to what's available. So your mind only thinks in 1s and 2s, because, most of them were only 1s. So 2s was a bit of a luxury. Now to have this additional double step change makes a big, big difference, because we're not sacrificing crown retention anymore. Because as you now bring up to a 4 millimeter, we can still have that chimney and angle it and cut it. So we've still got the ideal amount, whereas in the past, we'd be maybe dealing with a 2, and if we had an angle cut, well, actually, you're still losing a lot of the retention in relation to a tall anterior tooth, if you like. And that really is the key, because I know you or I are going to come on to cover this, but I'm going to very quickly bring up a slide. Now, this isn't an anterior, and I'm just going to quickly get that out of the way, and I'm going to share something with you. So we're going to share the screen. I'm going to show you that. Okay, so of course, Martin, we're very familiar with this slide. I know you know Dr. Linda Cooper incredibly well, but this is completely true. Now, this trade-off we've got between the crown height and the retention of the crown happens a lot with tie bases, because if you've got to drop down, the height of the tie base inside is dropping down with it. So again, Holger Zipridge wasn't looking at crowns here. He was obviously looking at implant interfaces, but the same thing holds true. When you look at Linda Cooper's work, I think the reason we see so many issues with those high crown to small retention ratios is all of this stress is at that neck. High crown, smaller base means you're going to get a lot more stress around the base or lower part of the crown. We don't have that trade-off anymore. By bringing it further up, it allows us to get away from that. I'm not going to go much further on into this particular slide, because it then goes into a case for a patient, Perry, Martin, that you and I are going to show. But I think when we get to that point, it's worth you showing that first, because there's two elements to that. There's the right positioning and then the right component, if you like.
Yeah, no, Steve, I mean, that's a great point you make. And Casper, I think when we were discussing this the other day, and, you know, speaking to you, your talk, you know, when you spoke about the evolution of tie bases, one of the things is, I think that I remember when we first started using tie bases, we were using things that were not designed for that purpose. Tie bases were designed so that we could use the tie base, mill some sort of zirconia onto that, and then make a cement retained abutment. That's what they're designed for. We then adapted them for screw retained abutments. And what's really, really interesting is this is, I think, one of those components that has been designed from the ground up to be a tie base, rather than adapted from another clinical use. And I think it's something that's, you know, this is something that's useful in modern implantology. Again, heights are really useful, etc. And I think I'm just going to just briefly kind of touch on this case, because this is a nice segue between what we had in the past and what we've got now. This is a patient who's come in. What you can't tell is he's got this tooth here that's failing. He's going to essentially end up losing that tooth. And this is him at the beginning of the treatment.
Mine. Sorry,
yeah.
I stole your screen. So I stole the screen, so you have to reshare.
Oh, sorry.
Yeah, sorry. I barged in and pushed you off. Sorry.
Let's have a look. Let me start there, and let's go for the share. I'm going to share the window. Let's go to that one there. Just checking. Oh, yeah, that's now working. So this patient's come in, and it's the story really of these two teeth that you see here. These teeth are essentially both going to get replaced. We started off by replacing the upper left one, and then having replaced the upper left one, he came in with a problem with the upper right one. This is where I showed you the scan of the previous tooth, because we needed to replace the upper right one, which has the root treatment. This is the upper left one we'd done previously. And what I'm going to show you is, again, photos of both teeth being extracted at the time he lost them, both of the times when we placed the implant. This is the interesting part. This is, at the time, how we made the provisional restorations. And if you have a look at one versus the other, this perfectly encapsulates why we need a solution like the HBG, because we've got all the things we've talked about. We've got the thing we spoke about. We've got our C zone there. We've got our bounded zone in there. We've got our aesthetic zone there. And we don't have this bulk and height in the area there that's in the crestal zone as we've had in the past. If we just follow this through, this is both cases on the day of surgery. This is the patient at the start with one of the teeth, and then with the provisional. And what I really, really love, and this is a picture that I think really, really shows what's happening. When we can see this picture just here, and we can see the profile of the custom abutment, and we can see the profile of the HBG, we can see that the engineers at Elos have done a really good job in taking on that feedback, so that this is the evolution, and this is how, you know, we could quite easily, should he choose to, make him a final in that material, sorry, for that restoration. And again, just looking at the evolution of how things have changed over time has been particularly interesting. So the other thing that I think we're going to talk through, and I think it's now time,
That
Steve,
is
if
nice
we...
as well, because it does show that deeper screw there. I love the way you can see that on the X-ray. You can see that offset
Yeah,
height of the screw compared to the other one. It's
yeah,
really good.
yeah. I mean, it's a great. You can see all the engineering that's gone into it. And again, if we're just going to again give Casper and his team a little bit of kudos, it's also how the screw engages there. It engages perfectly because the way in which it's been designed is based really on very, very sound biological principles. If we now just look at this posterior tooth, and I'm going to jump a little bit, and I think one of the key parts for me in using these posteriorly is making sure that we plan correctly. So even though it's just, lower left 6 and 7, if we know the component we're going to make, and again, we've not really touched on the digital workflows that are available, and Steve will show you some of those as we get to some more advanced cases. But in this particular case, we've been able to do the planning, and these are the crowns that have come back from Steve and his team at Nexus. You can see the crowns there, the zirconia crowns on the HPG. You can see that here the diagnostic wax up and the final next to one another. And we can see here the profiles again, when we've talked about emergence profiles, making sure that the implants are placed at the correct depth such that we can take advantage of a solution like this. And if I now just hand over to Steve to talk a little bit about the design, because that's when the patient is coming to see me. But again, a lot happens before the patient comes at the laboratory before that stage.
Brilliant. Thank you very much, Martin. Let me bring this one back on and just share this with us so we can have a look. Okay. We are. Okay, so we're picking back up then at where we left off to do with this. And the reason it's very relevant is if in the past someone had come to me and said, we're going to do a molar, my answer was pretty much always a resounding no. Like, absolutely not. We don't do that. We don't want to see these. Okay, that was our fundamental. As a lab, we've seen so many of these coming through our door to fix, and we weren't making them. But the issue here is actually the two things Martin's just, one of them is covered, is the ideal placement of it. And the other one is actually to do with what you're retaining that with. So, if this is off center, you've got a lot of cantilever load. We can see where the stress is. Of course, that's going to go. So we get the case from Martin. He scanned with the Elos scan bodies. And then obviously we're bringing it in now. Now you've got a library, and the library now allows you to select straight away in there. You can see the chimney. We've gone for the highest one. So I can see from the occlusal table, I can see where we are. I've got plenty of room for the highest one. You can choose all the different gingival heights, all of the different types. You discuss that, as we have done with Martin, live. We'll show it to him and say, what do you think to this height? What do you think to this height? So that we don't have this trade-off anymore. Yes, I've got the crown on the right, if you like, but I've actually now not got the tie base that sat inside it. I've got these. I mean, look at how much of the volume and space they take up there. These are a really good solution for this case. So it went from what would have instantly been a custom abutment in any time in the past, pre these, to a, yes, Martin, we'll make those for you. I think Martin's loving this because he's making me do things that we never used to do. It used to be a brief phone call. No, we don't do those. And we moved on with our life. And now we've got like solutions where it's like, okay, yes, we can. So we're not getting these anymore because look at that. And that is to do with credit to the planning and placement. They're exactly where they needed to be. I'm not worried about a heavy cantilever load. I'm not worried about them only having a short base and a lot of torsional load transferring that down. We've got a great retentive solution. So they go off to mill, models are produced, the HBGs go straight onto the model, zirconia just milled at this stage, not touched in any way. Then over to Dave, who's done some amazing work on this, of detailing them with the Mayo. He's a very talented ceramist. I'm saying this because he's right behind me and I don't want to get a shoe in the back of the head or something. And then, it's back and it's out. But I look at it from every angle and I have no concerns over this solution. In the past, I would have had concerns. And that's been a game changer because I'm not being protective anymore. That was the reason. I wasn't being awkward, Martin, when I was just saying no, we're being protective of our lab time. We're being protective of your time, because all of these failures, debonds, breaks, they come back on us all. You know, your chair time is you've got to readdress it, and our lab time is we've got to remake it for free. But that was a great case for it, because this was a custom every day of the week. So the semi-custom abutment it really has come into its own here. So I'm just going to stop sharing here on that one, and just hand back to you guys.
Yeah, a quick comment on that, Steve. Thank you for sharing. So you said normally that kind of restoration would be a custom abutment.
Instantly, because we're never getting a body high enough. You know, a lot of what we do is we take up and increase the volume inside, you know, with the customized abutment. And this is kind of the first time we've ever been able to look at it and say, okay, we don't need that now. So we're able to turn to a solution that previously we would never have considered.
Okay, I'm just curious then, because what does that mean for your efficiency in the lab when you have these options with the hybrid-based G?
Well, it's actually a massive leap in efficiency, because if I do a full custom design and then prep for mill, that's about 25 minutes. And I did some very sad and geekish calculations on this because I was trying to work out how much of my life I was spending doing this. So I'm just actually going to share my screen because I want to show you this, because I made it anyway. I might as well show it to you. So let's get rid of this. So in doing a few calculations, okay, can you see that?
Yeah.
So it's a massive increase in time. Like anybody who runs a lab will tell you, number one pain factor at the moment is time and capacity. So hybrid-based G versus these molars that I would have been making, custom abutments. So I've done 10,000, but I got an award recently for doing 10,000 custom abutments just since we started Nexus, which is, wow. Yeah, I know, that's a lot. But I worked out that to do the CAD design, then the prep for mill is 25 minutes in abutment. So that would mean 2 years, 1 month, and 2 weeks of my life has been spent on that task. I could have been doing so much more with my time. But if you look at this in terms of efficiency, it's 5 minutes. You saw me bring the bases in. We select and discuss those with Martin, and now I'm just designing the crown. That's it. The crown will be done anyway, so that's 5 minutes. So this takes 5 months of full-time employment equivalent. I've got over a year and a half of my life back. I mean, that is great news for me. It's not great news for other people, because that means going forward, I've got more time to be a pain for other people. But for me, it's a game changer, and for labs, it's a game changer. You know, this is a real kind of step forward in opening capacity with a new solution.
Great.
I think,
Thank you for sharing, Steve. That's perfect.
Sorry, Martin, go on. I won't be bothering you all the time. It's all right.
No. I think it. Well, I was worried, but I just need to send you some more complex case. But I just wanted to show you, Steve, what that looked like when it went in the mouth, because I know obviously you're there with your team. I'm here with mine. Just seeing what that looked like in the mouth. So this is the patient as they came in on the day of fit. You can see how that fits together very nicely. I haven't got a lateral photo. They're coming back for a review in a week or so, but you can see the process there and what we've been able to deliver to them. But what I've really quite enjoyed about this is, again, something that takes up a little bit of your time is, first thing is being able to do same-day prosthetics. So when a patient comes in, for instance here, who's lost his lateral incisor, previously, all the cases I've shown, we've had to plan in the past, but here this was an absolute emergency. We've extracted the tooth, placed the implant, a little bit of grafting, implants gone in. We've then taken a scan, as you can see there, and with the scan, we've sent the patient away. They've come back later that day for us to fit the temporary crown that you can see there. So that's them at the beginning of the day, that's them at the end of the day. So again, by having this component, meaning that we can have a very nice crown for the patient, you can see there the aesthetics, the function, etc., are absolutely ideal. We can also go a little bit further, and this, Steve, is something we've been working through which is, you know, having pre-made provisionals. So this crown that you see here is going to go into a patient where everything has been digitally designed, and we're going to do some guided surgery. But this is again where there's another strength of this particular this particular solution. Here we've chosen the non-indexed version, meaning that when I place the implant, I don't have so much of a reliance on the position or timing of as the implant rotates. I can put the crown in the right area at the right time. So Steve, I believe you did a little bit of planning for me, and you helped on this case. So I'm just going to step away from sharing the screen.
Steve?
Yep, thank you very much. Okay, so yeah, well, okay, and this again is one of the things that I love, because this isn't just to do in one side. This is a library and integration into the planning. So obviously it's a case that you set in mind. So you've done the planning. So we did a diagnostic file. We sent it to you. You imported it, and then you put it in for the planning. Now the great thing about that is we can now instantly visualize. You see that blue at the top, the HBG. So if you look just to the right of the X-ray there, or the CT, you can see we're actually choosing at that time. Martin's able to visualize where the HBG is going to be. So now we have the opportunity that Martin can choose to position his implant with the confidence, even if he's going buccally, knowing where that HBG is likely to be. That was a bit of a game changer, because it meant that we could take the planning, make him his guide. But the best bit was, after we did that, we imported the file straight into ExoCAD, and we took that, we made the angle cut. So again, we've shown you the angle cut before, but this is it in real life. So Martin was showing you a case earlier where yes, he could get the depth, but he couldn't get the angle cut. So here you can see on the left, that's us having the angle cut coming back. And that allowed us to send the crown to Martin. Now, normally you send shells and they've got to do a pickup, bond it to a base. There's a lot of chairside work there. We delivered that, which is a complete game changer, because actually it meant that Martin was able to do the guide, take this to the mouth, and have the crown delivered as was designed on the right-hand side in the ExoCAD. And you can see there the very high base, the angle cut, and everything's in there. And you can also see the high chimney. So this is ideal for us to do with this case. And that for me is one of the really interesting things, because this allows for that, you know, immediate provisionalization, but without all of the extra mess and faff and well, I mean, it's really probably more something you can talk to, Martin, because this is chairside time that's then taken up when you're doing these pickups and cleaning and bringing it back. So I'll hand it back to you for that.
I mean, absolutely. I mean, I've not quite had the time to do my little calculation on how many years I can bother my family for as a result of being able to speed up my workflows. But this is going to, I mean, to give you an idea, when we did this, and I'm just going to jump back on for a second. When we did this case, we normally put aside, I'm going to say, maybe 2 to 2.5 hours for an immediate extraction, placement, temporization, etc. So as we go through, and I think one of the things that's interesting in this case, you can see the height, you can see there the amount of bone, where the bone level was buccally. So we were always going to need some sort of tour, note 4 millimeters Casper, collar height in there. And we can see here that's the implant going in. We're making sure we get the timing right. I'm going to talk about this at the end, about the importance of that position. And when we just knocked this off and finished, my nurse looked around at me and goes, "Is that it? Are we finished?" Because she was expecting that the minute I connected something up to the implant, that was the start of a 25 to 45 minute process of making chairside a provisional restoration. And the other thing that's interesting, in cases where we've got this nice thick biotype, we're not needing to soft tissue graft. What I love about this is the patient on the day, this is the patient on the day of surgery. They go leave absolutely thrilled. It looks very nice. It's completely acceptable. And this is them when they come back. So you can see how nicely the tissue is healed around the components. And when they've come back for a review, this is the PA immediately afterwards. This is at a roughly, say, the 3-month review before they go back to their referring dentist. And we can see here again, another thing to point out just on this, we can see here Again, what I love is this is what the correct profiles give us. In those areas where we've got the blue dots, we can see how we've managed to maintain the bony peaks and hopefully, again, keep bone up to that level on these implants. So again,
that's the one thing I was going to say. That's, I mean, we look at those and you can see how close it is and how it's bringing it up. It's great.
I think rather than the ones we've shown where everything has been much higher up, and I previously always used to have to get the collar height and trim a lot, trim and shape and trim and shape and trim and shape. I didn't have angle screw access, so I'd have to, you know, struggle or do something else in those cases. But having the option of 4 different collar heights, angled screw access, and then to tap it all off with a digital workflow to have the pre-made prosthetic that you just pop in, and once it's in, that's it. The patients love it. I love it. It's again a time saver for both of us.
It sounds like your nurse loved it as well.
We did. But there are a couple of technical points that I think it would be good to address as part of this. And when I've said that, the first is this, which is where is the 7th spline? This is specific to the EV platform, where we have effectively a 3-in-1 connection. We've got a connection where we can use it non-indexed, which I've shown you, and then the index has the option of using the 7th spline. And the positioning of this spline is important because, as you can see here, where we've got the blue arrow points to where the spline is. So this means that the spline should be placed buccal to take advantage of where that angle correction is. And again, Casper, out of interest, when you were talking through this and coming up with this, what was your thinking as a team behind this?
Well, to be brutal honest, I'm not sure that there was a thinking behind it, but the EV platform is great in the sense that we, from a scan body point of view, we pick up that 7th index, and the hybrid base G only uses the 6th index, so you can actually turn it 60 degrees when you do the prosthetics, which allows you to make sure that you have the angle screw channel in the specific point that you actually want, also from a aesthetic point of view.
Yeah, so again, with that in mind, I mean, we still have the freedom of the kind of 6 indices, but also knowing that if we put that buccally, it's much easier when we're scanning for the lab, if they're trying to pick up effectively on your scan bodies the exact position, it's better if that's slightly buccal.
Yeah, and as we talked about, well, the protocol for that dictates the 7th index to be on the buccal side, but you could also argue, well, if you depending on the two positioning, you can tilt that a little bit to make sure that you have the angulated screw channel in the direction which is most optimal to actually access, and having that knowledge to be aware of that during the planning phase, I think that is important.
Yeah. And I think the other thing I want to talk about is, again, this has come from Steve and I using this solution. What you can see here is, you can see the first thing you're seeing here is this is the standard tie base that I would have used. And you can see here over a period of time how, I'm just going to undo that. You can see here over a period of time how we've got this fracture here. As we've had force this way, it's caused that fracture that you see. So by having something that's taller, we're going to resist some of that force. However, the positioning of this, I think, really, in order to take advantage of, you know, of everything we've talked about with the ideal emergence profile, if I was going back again, I would have a slightly taller hybrid base there, because I feel although it's fine from the lateral aspect, it would be nicer at the time we put it in if we just moved that collar up a little bit, or alternatively flared out the tissue, flared out the you know, built up some material in and around there. But again, these are technical points, and the more of these we do, the more of this that we're learning between Steve and I as we work with the hybrid-based G over time.
Martin, just look at those images. Do you mind if I just ask a question? Because we saw a lot of, so anterior implants, we saw a lot of them in place, but they were all being placed, you know, quite vertically. So they weren't really on a tilt. And I think that's because everyone was trying in their mind to plan for the day when they were delivering, knowing they'd have a straight tie base or a straight temp cylinder or whatever. If, when you now look at a case, now that you know you've got an angulation in, are there more cases in the anterior where you actually are going to take more advantage, it is a benefit to tip it, because I notice a lot of the cases we see, they seem like they're straight up, and if they were slightly tilted, you'd be able to use a longer chimney and have the angle cut on.
Oh, I mean, absolutely. This is where really having the ability to be able to see this stage, right, the ability to be able to see this stage in your planning software means that you can look at it. I mean, this is going to a different level, Steve. We've talked about prosthetically guided implant placement, making sure it's in there. We've talked as well about materially guided, i.e. making sure we have the correct thickness of material around whatever component we're going to put in here. This is going to a different level, because by being able to decide the component and the component shape and customize that at the beginning, to have the right thickness of material at the time we do it, to have something that will be super retentive, because a lot of where, you know, as you say, in the past, I was really trying to upright everything. That was the thinking with immediate implants. Upright, come through the cingulum. The natural position on most incisors is actually to come through the incisal edge. That's the natural position that you would want to put the implant to take advantage of the, you know, the shape of the maxilla. The better bone, the longer implant, the more likely to get primary stability. Now, if we're combining that aspect with a component that means that we're then getting much more support on the crown, that's a win for the surgery, and that's a win for the prosthetics as well. So I think that there's a lot to be said for that.
Yeah, and that just reinforces what you were saying earlier. This isn't like a taking of a solution and kind of adapting it. This is really thinking of a completely new solution, which allows a completely new way of approaching what we've all been doing and trying to eliminate the compromises. I mean, you know, it really impressed me, some of the things we've been able to do with this unexpectedly.
Oh, great. Thank you both so much for your insight. And as I said earlier, you're definitely really good at talking when we're talking about dental. We have just a few minutes left, and I thank you so much for your insights. I really want to touch real quick about bonding, because that is something that is crucial for us and extremely important for us. And Steve, I believe that you can't remember when we reached out to you some years back when we wanted to start a study on bonding and the retention strength that we can get from bonding. So long story short is that we reach out to you and other labs and ask you to bond a number of different restorations in the normal aspect of how you would bond your restorations. Then we took them back. We measured the retention strength, and what we saw, and it's not putting you out there, Steve, but what we saw across the board was, well, there were a lot of difference between the same restoration cemented on the same type base. We did like 10-15 samples, and those 10-15 samples were basically all over the spectrum. And based on that, we sat down to do a study where we looked at different impacts on retention strength. And I'm just going to run through it really quick as in the end of this webinar. But basically, as you see on my screen, this is some of the key highlights from our white paper. So the white paper is available on our website. We have been looking at what we call abrasive blasting of the zirconia. We've been looking at cement gap size, and we've been looking at cleaning agents in all different segments. And I think what I'm going to be highlighting here is one thing is the cement gap size. We can see in the graph here that if you have a very small cement gap size of 20 microns up to 80 microns, we actually see not a big difference in the average strength of retention. So this is a pull test that pulled the type base from the zirconia, but we see a difference in the spread of the different samples that we tested. So when going from 80 to 20 microns, we see a big split. Normally, we would have a cement gapping in our libraries of 40 microns. Based on our study, we have actually increased it to 60 microns to make sure that we have enough cement gap between the crown and the type base when we do the bonding, because we see a more uniform result in the retention strength. When it comes to the cleaning agent, and this was our biggest surprise, is that the steam cleaner, which I think is very commonly used on the lab side, while it cleans visually the typase and the restoration, it somehow leaves behind maybe some kind of residue or some moist or some oil. When we did the test, we saw a really big spread again in the samples that we tested, and we saw the lowest average retention force. When looking at a cleaning agent that often comes with the cement, or simply using alcohol, we saw a very nice condensed spread of all the samples, and we saw a very high retention force. So based on this study, we are recommending to use either an alcohol when you do the cleaning of the typase and the restoration, or a cleaning agent. But it's actually not only our study that shows it, because I have some samples from this study. This is a study from the University of Alabama that tested on a typase that looks very similar to the Elos one, meaning that we have mechanical retention built into it. And in this study, they tested a blasted, a titanium base that is blasted versus a base that is blasted but primed with the primer for the cement, and then simply a no surface treatment up against a primed one. And we really see a huge difference when we're looking at a sandblasted typase and a non-sandblasted, which I think this is very interesting, because you touched upon it earlier, Steve. I think a lot of inherited knowledge dictates that whatever you're gonna bond on needs to be blasted, needs to have an abrasive surface. So what's important when we talk about the Elos hybrid bases, and also the hybrid base G, is that these are hybrid bases that has built-in mechanical retention. In these pictures here, we see a similar typase with mechanical retention before and after sandblasted. So the mechanical retention in the design actually gives you these very sharp edges where the cement kind of creates this mechanical retention. And when you blast that, you actually end up smoothing the surface, which was meant to be very rough and abrasive and having this mechanical retention. And the blasting not only reduces the retention, it can also, in some instances, also create microfractures in the typase that can lead to breakage. So this study is actually extremely interesting. I listed it here as well. But if you go to our website, you will see the white paper that we did that covers the same point. So for us, again, cleaning is important, and absolutely no blasting of the typase. However, we do recommend blasting the zirconia, and that's why we tested the 100 micron and the 50 micron zirconia nitride for the blasting media. And here we would recommend the 50 micron blast media for blasting the zirconia only. Again, never the typase. Just some of the finishing remarks I would like to put on when we talk about hybrid bases in general, because I think it's important for us to cover that. And that leaves us actually with just a few minutes to spare. So if you have any closing remarks, Martin or Steve, please let us know. But nevertheless, a big thank you to you both for helping us hosting this webinar. It's been great to hearing your insights, your valuable insights into both the development of these products and to the use of it. I'm extremely happy that you were able to spend the time with us here today.
Thank you very much, Casper. One of the things I'd like to say, my closing remarks would be that this has a place for you if you're able to utilize it correctly. And again, with the use of digital workflows, this will really, really change what you're able to do. And hopefully, in a selection of cases, you've seen how this is possible. And thank you and your team for being so responsive and it's been really refreshing to give feedback, and that feedback has then been taken back through the research and development and has come out in the product, which I'm hoping the marketplace and people will reflect on it by being able to use it. So thank you very much to you and your teams, and Rebecca as well, for this webinar.
Thank you, Martin.
Yep. Yeah, and that's it. I've got to say exactly the same. You know, it's so refreshing to offer feedback and then see that actually resolved and a new product come out that sort of answers those issues. So, for me, just thank you very much for being part of this. It really has, it's really changed everything. We've now got new pathways, new solutions, and also know not to steam clean everything and not to sandblast everything. So it wasn't just the components, it was actually, the research and development. So thank you very much.
Thank you, Steve. Thank you, Steve. So lastly, to our audience, thank you for joining us. And we do hope that this discussion has been helpful to enhance your own workflows. And if you have any questions and would like to know more about our products, please do not hesitate to reach out to us. Once again, thank you for your time, and we look forward to seeing you in our future webinars. Have a wonderful weekend. Bye.